And now it is my great pleasure to introduce Dr. Isla Domostrup, who is from Kennedy Krieger Institute in Baltimore, Maryland. So we came across her because she is Wendy's personal therapist. So she agreed to speak at our Baltimore conference in 2017, and she's been back ever since, which is a wonderful blessing to all of us. She is a licensed psychologist and doctoral level board-certified behavior analyst at Kennedy Krieger, and she's also an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine in Baltimore. She received her doctoral degree in school psychology from the University of Georgia, and she completed her internship and fellowship training with the neurobehavioral programs at the Kennedy Krieger Institute. For the past decade, she specialized in the assessment and treatment of severe problem behavior exhibited by individuals with intellectual and developmental disabilities, with an emphasis on caregiver training to promote meaningful change in the lives of not just her clients, but their families as well. Dr. Domostrup is very passionate about mentoring and supervising new clinicians and behavior analysts to prioritize socially significant outcomes for the clients and families they serve. And one of the things that always impressed me about Dr. Isla is Wendy would have some strange behaviors, and you just get used to it. And her thing is, okay, but that's affecting your quality of life as a family, which was kind of an interesting thing. Like, yes, we might deal with it, but dealing with it or ignoring it is probably not the best thing to do. We probably need to actually address some of the behaviors. So she's been very instrumental in that, and she's going to be talking to you, one, about some consultations she's doing, and then she's also going to be giving a talk about behavior. At this point, as a licensed psychologist from Kennedy Krieger, she's probably the authority on 1P36 behaviors. So, and also for you Canadian families out there, she's originally Canadian. I'm just going to out her. So. Every now and then we celebrate Canadian Thanksgiving, and Dr. Isla has come and joined us. So, without further ado, here is Dr. Isla.
Okay, I'm going to try. All right, so to jump right into what I'm going to be talking about today, for those of you that were here last year, I promise I'm going to try and speak a little bit slower than I did. I got really excited and talked really fast, so I'm going to try and tone it down a little bit. But as you can see from the slide today, I'm going to be talking about ABA, or Applied Behavior Analysis, and really trying to dig into a little bit of the good, the bad, that you may have heard about that, and the questions that you should be asking as you move forward with possibly pursuing that line of therapy for your child. So briefly, because I can't not have a bit of an agenda, I'm going to be talking a little bit about the background of ABA, both in some technical terms, but also some hopefully more accessible and understanding ways to help you guys get a really good grasp of what ABA is. Talk about some of the good. Then I'm going to dive into some of the things you've probably heard, and a lot of those may actually kind of be bad, and share some information about those things that you've heard and talk about that a little bit. And then hopefully give you some ideas or things that you need to remember moving forward, and specifically some questions you should be asking as you start this ABA journey. All right, so what is ABA? Well, according to the Behavior Analyst Certification Board, bear with me here, behavior analysis is just that, the science of behavior. It's based on the premise that attempts to improve the human condition through behavior change will be most effective if behavior itself is the primary focus. So applied behavior analysis is largely based on behavior and its consequences. So techniques are generally involving teaching individuals more effective ways of behavior through positive reinforcement and working to change the social consequences of existing behavior. What am I talking about, right? What am I saying here? Let's break that down a little bit more. Literally looking at the three terms that make up the phrase ABA. So, applied, part of applied behavior analysis. Applied means that a target that you're looking for is selected because of its importance to the individual, the family, or a specific context. So this isn't saying that all children need to be treated for eye contact or things like that. This is picking a behavior or a target that is meaningful for you, for that individual's well-being, and can be representative across multiple contexts. So if challenging behavior is occurring in schools, maybe it's looking at working to hand raise, right? Raise your hand in class. That can be really relevant for certain kids. Maybe if we're looking at feeding-related concerns, it's about the family wanting to be able to go out to any restaurant and not just a specific restaurant, and having a child learn to order other types of food, or maybe that's just dietary, right? Eating a healthier diet, that can be important at the individual level. A big part of what I've spent a lot of my time doing is looking at communication, right? A lot of individuals with developmental disabilities are using challenging behavior, inappropriate behavior as a means to communicate their wants and needs. And so we need to figure out a way to identify more appropriate communication strategies. So that's what we talk about being applied. It's selected because it's socially significant and meaningful for that individual or their family. Next, B, behavior, right? ABA, behavior. So here, when we talk about behavior, this can get tricky, okay? A behavior, when we talk about behavior in ABA, it needs to be something that's observable, measurable, and precise in definition. And now this can be hard for me because sometimes I have families come to me and say, well, we need to work on their frustration. Okay, well, what does frustration look like, right? You may know it when you see it, but can you define it in a way that another person can come and see it? Some of you might be frustrated right now, right? And I have no idea because you're not showing it in a way that's measurable, observable, or easy to be defined in that way. Another one is on-task behavior, right? That's another example or non-example of a behavior, right? You may say, well, yeah, you can see when someone's on task, but can you? Can you really do it in a way that's measurable and that's precise in that definition? Similarly, another one that could be relevant right now, listening, right? Many of you are looking at me, you know, some of you are nodding your heads, but you could have your headphones in listening to the Olympics, right? You could be thinking about what's going on for mom and dad's night out later and planning your cool 80s outfit and not listening to me. And I would have no way of knowing that because that is not really a behavior that is observable, measurable, and being able to be precise in definition. So these are non-examples of behavior to help you understand sort of what me as a practitioner and what you as a parent, when you're thinking about, hey, what are the behaviors I'm concerned about or what are the behaviors I want to target, think about, is it something that you could actually provide a definition to that you could give to someone else and they would be able to observe it in your child? You following me on that one? Okay. The next A is analysis, all right? So here, when we're talking about analysis in the terms of ABA, that means that we want to be able to demonstrate through measurement that an intervention is responsible for a behavior happening or not happening, all right? So let's take another example. As someone said earlier, there's a lot of runners here, right? Now, running away, even that can be a hard behavior to define, but you know what's an easier behavior to define? Holding your caregiver's hand, right? That one's pretty clear. You can see it when a child's holding their caregiver's hand. You can measure it. You can say, yes, they're holding their hand, and that's easy to define. So if we take that flip side of the target we want to work on for this individual child is holding their caregiver's hand, then we want to be able to measure, and I'm not going to go into explaining this whole graph, but I will just touch on briefly that if hand-holding is our behavior we're looking at, that first little section there, we would say, oh, hand-holding is not happening very often, right? It's really, really low. Then we do some intervention, and in that second little phase, we see that hand-holding improves, right? We're able to measure that through this analysis phase of ABA. And then some cases we say, hey, is this really because our intervention? And we remove the intervention, and we say, oh, yep, hand-holding went down again, so our intervention was hopefully working, and when we put it back in place, we see that hand-holding go up, and now we've had a meaningful change, right? So we've targeted and applied an important behavior for this family, a behavior that's measurable in the sense of hand-holding, and we've been able to measure and analyze that our intervention was having an effect. So if we're breaking down what ABA is, this is what we're talking about, targeting meaningful, socially significant behaviors and collecting data and being able to measure the effects that our interventions are having or not having in some of those situations. So I want to take a second here to just reference that this is not new. So I think ABA has been in the press for a lot of reasons recently, but ABA has been around for a really, really long time. So long, in fact, that in 1968, Bear, Wolf, and Risley published an article looking at what they called at that time the current dimensions of ABA, and I'm going to tell you a little bit more about those. But just wanted to give you a little bit of a background that we've been talking about how things are applied, behavioral, and analytic, as well as some other dimensions for a very, very long time. We're talking over 50 years now. They actually published a second paper about 20 years later where they basically said just that. Hey, this is still relevant. This is stuff that we need to be doing. Our field needs to be prioritizing these things. And this is a conversation that those of us in the field are still having today. So here's a visual of the 7 dimensions that they outlined back in 1968 about what needs to be considered when we're talking about sound ABA practices. So I already touched on these 3, right? Applied, behavioral, and analytical. But I want to touch on a couple other ones here that I think are pretty relevant for the conversation that we're going to be having across the rest of my talk today. So the first being conceptually systematic. All right, this is where we talk about the fact that ABA strategies and interventions are research-based, and again, are emphasizing the principles of behavior change, that we are looking at targeted, meaningful situations for an individual and using evidence-based, peer-reviewed approaches to improve or decrease the behavior that's being targeted there. Now, I didn't say this up front, but a lot of the resources I'm looking at here will reference autism specifically, but let me be clear that ABA can work with anybody, and there's so much research out there showing that ABA is effective with children, with adults, with a range of developmental disabilities, neurotypical individuals, working on substance abuse disorders, looking at whole staff compliance and improvement in behavior there. So ABA is really not specific to autism, which I'll touch on again later, but I did want to put that out there right now. So as I was saying, the New Jersey Autism website has this really, I think, helpful visual way of looking at a lot of the treatment interventions that are out there right now, and using a red, yellow, green light sort of system to indicate whether these interventions have been shown through research to be effective or not for individuals with autism. So as you can see here, these are the red light examples of interventions that have actually found to be harmful and ineffective for individuals with autism. Here is their yellow tab, so this includes sections for interventions that have maybe some preliminary evidence suggesting some effectiveness, preliminary evidence suggesting ineffectiveness, and a large area where there's a lot more research needed. So this isn't to say, like, don't necessarily do any of these things, but just look into it, right? This can help guide some information gathering for you as a caregiver. And in terms of the green light, in terms of treatments that have shown through research to be most effective, ABA is one of the main ones. And everything listed under that applied behavior analysis heading there are all different approaches that are all considered behavioral analytic or fall under that umbrella of ABA. The other approach being medications, which I'm not an expert in, but yes, Risperdal and Abilify have the only FDA-approved medications to work with irritability associated with autism. So the other dimension that I wanted to talk about that I think is really important and is the area that I am most passionate about is generality. So here we're talking about whether learned skills can be demonstrated in different settings and under a variety of contexts and maintained over time, right? We can do a lot of things in a clinic setting. The clinic I currently work in is made of blue padded rooms where we can isolate and look at that measurement piece and those behaviors in a very precise way. But that doesn't matter if what we're working on can't also be applied to the home, the community, the school. You know, sometimes it's a matter of, hey, what you do in the basement during your ABA therapy sessions, will those interventions translate to the kitchen, to a different area of the house? And so we want what's learned in structured teaching environments to be able to be applied and generalized to a meaningful environment for that individual and for that family. All right, so jumping right into the good, or what I consider the good parts of ABA. ABA is meant to be individualized and meant to target socially significant behaviors to the client and the family. And if that's not happening, then that's not good. But I think that's what I love about this field the most, is it is truly designed to be individualized and look at what's important at that individual level and not about big picture changes on a large scope. Research isn't looking at group designs. It's looking at individuals and how we can help make their lives better. Another part that I like, because I'm a nerd, is that progress should be measurable, right? The lack of progress is also measurable. As much as I hate when my data doesn't go the way I want, I love that I know that quickly, because it means that I'm understanding that the intervention I'm working on might not be working the way I wanted it to, and I can make a meaningful change sooner than waiting for a test to happen 6 weeks from now to tell me that something's not working, right? We measure things in this way so we can know, are we on the right track? Are we needing to make a change? And we're hopefully spending less time guessing or being unsure because we've done such a good job defining how we're going to measure if progress is being made. As I already stated, another part of the good is that there's such a huge amount of evidence-based research to help us guide our interventions, and this is not specific to autism. We can look to the literature as practitioners and say, okay, I have a client who's engaging in, as Jennifer mentioned, maybe a very unusual behavior that's challenging and interfering with the family functioning. I can probably find some research out there that's going to help guide which intervention I approach or what data collection procedures I'm going to take as I look to help this individual. Are those some good things that maybe some of you have heard? Yeah? Okay, great. All right, so now to get to the tough part. Let me take a sip of water here. So, what maybe you've heard out there? ABA is abusive. Who's heard that? Couple hands, okay. ABA teaches people to hide who they are. Is that one some people have heard? Yeah. ABA focuses on punishment. Is that one people have heard? Yeah, okay, a couple hands out there. So, these are things I've heard. I've heard these things a lot, unfortunately, and I take these thoughts as a practitioner very seriously, and want to spend some time breaking that down for you guys in case you do hear this moving forward, or if you've heard it and you want to understand more. So, first, when someone says ABA is abusive, I want to acknowledge right off the bat that all reports of abuse need to be taken seriously and investigated. That if someone is claiming they've been abused via any treatment modality or therapeutic intervention, that should be taken incredibly seriously and reported and investigated by the necessary authorities. When it comes to some of the specific examples that I've heard within the context of ABA, some of these represent sort of shifts in time, right? So there has been a lot of change in how we approach interventions since the 1960s. So as an extreme example, I'm going to read something here about the use of electric shock, which was condoned in the 1960s to stop children from engaging in their obsessive and repetitive behaviors. Over the last couple of years, there's been a lot of discussion in the field of ABA about this, as there's still one place in the United States that uses contingent electric shock. It's the Judge Rotenberg Center in Canton, Massachusetts. And the Association for Behavior Analysis International actually released a very long investigation document and statement, but where they say, I'm actually going to read it on my phone because I think it's a little bit easier for me to read there. Contingent electric skin shock is a positive punishment procedure that has been used for decades to rapidly reduce problem behavior. Advances in applied behavior analysis, in particular refinements in methods for assessing the function of problem behavior, have drastically reduced the use of positive punishment in general and contingent electric skin shock in particular, accompanied by an increase in the number of individuals with severe behavior problems who can be treated effectively in programs based on principles of positive reinforcement. As matters stand today, these principles constitute the foundation of the professional practices of ABA, and they are essential to ethically sound and effective treatment programs. Today, contingent electric shock is not the standard of care for the treatment of problem behavior. That would seem obvious, I think, to most of you, right? But again, there's still a place here in the United States that uses this approach. Do the individuals who experience that consider abusive? I don't know. But that is just an example of a practice that was previously used in a wider scale that now horrifies me that that was done, and that changes have happened in the field. As the same with medical practices, right? Those procedures have changed over the course and the trajectory of time. Specific to where I work, for a less extreme example, 30 years ago, before I was there or studying this, they would use spraying a child with water as a procedure to try and work on target behavior. Obviously, we don't do that anymore, and it kind of, again, baffles me that that was ever thought of as okay, but it was. And things have to change, and we have to have that collaboration and feedback from clients and stakeholders and take it very, very seriously to continue and evaluate all of our behavior analytic procedures. So when we hear something like ABA teaches people to hide who they are, This is kind of a concept called masking. Has anyone heard that phrase before? Masking? Yeah? Okay. I think it's most commonly talked about with the autism community, but I think applies to any mental health condition. And this term is really defined as when an individual represses or hides sign of their mental health condition to blend in or adapt in the neurotypical world. And this is a very serious concept. I don't think that ABA in and of itself is responsible for this. I think there's a lot that has to do with societal pressures just in general. And certainly there's a lot of evidence to indicate that masking can lead to anxiety and depression in individuals who feel the need to do that, whether they're doing it subconsciously or not, and is a really serious thing that we need to keep being aware of and drawing attention to, and helping with developing strategies to support those individuals who experience additional mental health crises because of the feelings of masking, but also practitioners to remember that it's not about making someone adapt to their environment, but help them be successful and be the best version of who they are. Another element that I think goes into this thought is, as I just talked about database decision making and measurement, that somehow equals very rigid approaches to intervention and just being driven by a protocol, as opposed to being driven by that applied piece of it, right? Where we need, that's my next point, where we need to remember that while we're taking data, while we have procedures we want to measure in a specific way, the goal is always about making it meaningful for the individual, for the family. And if we ever have a family saying, I feel like you're trying to make my kid hide who they are, we should immediately change our approach to something happening there. And if you are a parent feeling that a practitioner is encouraging your child to hide who they are, bring it up to them. And that's going to be something we talk about a little bit more later. ABA focuses on punishment. So I'm going to spend a little more time here because I think the term punishment is, unfortunately, not used appropriately or not correctly. It's sort of a bad word in terms of how we define it in the world of ABA. So again, to get a little technical for a second, a behavior analytic definition of punishment describes any context in which a response is followed by an event that results in a decrease in the probability of similar responses in similar situations in the future. So what that means is that if a behavior happens, good, bad, or otherwise, and then some sort of event or response from someone else happens, and the outcome of that is that initial behavior doesn't happen anymore, that's considered punishment when we talk about it from a behavior analytic frame. And I'm going to give you some examples. So if your child reaches for a hot stove and you yell at them, and then we learn, oh, they don't try to touch the stove ever again, yelling was punishment, right? You did something in response to a behavior that resulted in that behavior not happening again. So yelling is punishment from a behavior analytic frame. Now, are you guys all going, I didn't mean to punish them, right? Like, punishment isn't a bad word in some ways. So I really want you to understand how we think about it, or how a behavior therapist will think about it. All right, a student is disruptive in class and removed from the classroom, sent to the principal's office. That student is no longer disruptive in class. They never see that again. So here, removal from class and being sent to the principal's office was a punishment procedure because it resulted in that behavior not happening again in the future. All right, still with me? Here's another one. A student raises their hand and provides a detailed answer to a very difficult question in class. The teacher, who's super impressed, provides praise, acknowledges that student in front of the rest of the class, saying how thoughtful and well thought out that response was. And the results after that is that the student never raises their hand in class again. That public praise and acknowledgement was punishment, if we think about it in that behavior analytic lens, right? Because while the teacher thought they were providing praise and reinforcement, and that's going to say, like, yes, the student's going to raise their hand again, the result, which they could not have predicted, is that student no longer raised their hand. They did not like that positive praise or public praise and acknowledgement, so it served as a punishment procedure. Is that making sense? Right? So when a behavior analyst talks about punishment, we're not saying go to timeout. We're not saying aversive stimuli necessarily. We're saying a procedure that results in a behavior not happening again. Okay? So when we get back to that main thought of saying ABA focuses on punishment procedures can be an effective tool in a comprehensive intervention approach. But they really, really, really need to be used in conjunction with reinforcement procedures. And I know I didn't touch a lot on reinforcement today, but if you're ever working with someone who says, oh, we're going to try this punishment procedure just right out the gate, red flag, right away, red flag, okay? So punishment procedures, when we talk about them reducing a behavior, they can be effective. But again, if they're used alone, it's not really teaching anybody anything. The emphasis in ABA is working on teaching adaptive behaviors, identifying pro-social skills that we want our clients to have. And if we're just trying to reduce a problem behavior or reduce a behavior, we're not improving or teaching a replacement or alternative behavior. So we really don't want to be thinking about punishment procedures used alone, and generally want them to be thinking them as more of like a last resort. All right, so now getting into the bad part of some of this that I'm talking about. So this may be a weird sort of comparison, but in some ways thinking about someone becoming a BCBA or a behavior analyst, it's kind of equivalent to like a driver's license, right? You take a course, you pass a test, but that doesn't mean you're all on the same skill level, right? The majority of people here probably have your driver's license. I'm not gonna ask anybody to disclose if they're a bad driver, but they exist, right? We all agree there are bad drivers out there who have passed a test, have a license, but we might say they shouldn't be on the road. Unfortunately, the same could be said about BCBAs, right? We take coursework, we pass a test, and we have that credential to go and practice. That doesn't mean we're on the same skill level, right? Maybe your training wasn't as great, maybe how you like to approach things, you're forgetting the foundation, those dimensional skills from 1968 that we learned from Beowulf and Risley. And therefore, you know, it's not that ABA is bad, but there is bad ABA out there, if that makes sense. And that can be the part that's really concerning in the larger scope of the field. I won't say this is a red flag, but if you do work with a BCBA and you want to just throw out a question like, have you read Beowulf and Risley? That will be a good sign, because that's a really seminal article that everyone should read when they're taking their BCBA coursework. So the bad is that, you know, there is a history of past practices that at this day and age we would question, right? At what point was this determined to be okay, and how was that determined to be okay? So maybe this isn't the bad exactly, but we need to keep collaborating and learning from past practices and current social validity measures from our stakeholders, from the clients that we serve, and use that to inform our future directions. So that being said, I'm going to get into this in the questions you should be asking, but if you're working with someone who's not taking into consideration what you're pointing out as concerning to you, again, red flag, right? Another part of the bad, in my opinion, is that access to ABA as it's defined by insurance in a lot of situations requires a diagnosis of autism in many states. This is bad because, again, ABA isn't only just for people with autism, and we need insurance and we need legislation to really catch up and recognize that these behavioral approaches, if you remember from the very first technical slide I said, it's focused on behavior, right? The emphasis of ABA is that behavior itself is what needs to be targeted. We're not targeting a diagnosis, we're targeting a behavior, whether that's a behavior we want to reduce or it's behaviors we want to increase. And so this part is bad, in my opinion, that so many people here who have lots of goals that could be targeted through ABA but may not have a diagnosis of autism are going to be limited in how they can access this type of service. What I forgot to put on this slide is also age, right? ABA doesn't just work for children, it's not just early intervention. Anyone can respond to ABA, but again, insurance has really limited some of that access by saying nobody over 18, or even some of the providers. In Maryland, there are a lot of providers who say they can only work with children up to 16 or 18 for any number of reasons. I will say, if you're willing to fight for it, you can access it. There's a client I have in New Jersey who I still work with who's an adult, and his mom recently fought like heck and got some insurance coverage for him, even though he's over the age of 21, to get ABA services. Then she had to go through the process of finding an agency, and we just figured that out too. So it does exist. It needs to be out there more. And so sometimes these battles are laying ahead of you guys, unfortunately. All right, so what you need to know or what you need to remember. All right, if I haven't made this clear enough, you, as a caregiver, as a stakeholder, should be an active member of your child's ABA team. right? You are the one helping guide these decisions. You are the one that's identifying what are these meaningful, applied, socially significant targets for your child and for your family. The provider is not always right, but neither are you, right? This is where collaboration really comes into play. You know, if you say, hey, I want my child to learn to make their own lunch, you know, that's a pretty big skill. So not to say that the provider should come in and say, absolutely, that's not possible, but the provider may say, okay, well, we got a lot of fine motor skills we got to work on before we get to that goal, right? That's where that collaboration is key. You are going to be the expert on what you want your child to work towards. Your BCBA should help support that through their expertise of saying, great, these are the skills we want to see to get to that goal. And the other thing you need to remember is ABA is many, many things, right? And it needs to be tailored to your child's individual needs and development. So if you have a provider who comes in and says, here are the exact things we're going to do before they've even met your child, get out of there. That right there is not a good sign, because there's so much that needs to be taken into consideration about your child's individual needs and development before you can determine which treatment approach you're going to take, what assessment approach you're going to take, how are you going to define those behaviors that you want to measure moving forward. All right, so here's the big stuff, the questions you should be asking. I've broken these up into 5 kind of themes that I want to go through with you, and I think this is going to tie back to some of the stuff that I've already talked about. So when we're thinking about assessment and goal development, the questions that I think you should be asking is, how will you assess my child's current skills and develop goals for services? So there are standard assessments out there that are really commonly used and are great assessments, like the VB-MAP or the ABLS, and they can be really helpful for a provider to look at your child's current skill levels across personal hygiene, across communication, across safety awareness. So these are really common and, again, really great tools. And you should want to hear that a provider is going to use something like this when they're starting to do that initial assessment and help develop those goals. Now, I put this section as the questions you should be asking, but I also think there are questions that you should be aware of that you should be asked by a provider. And the first one being, what are the goals for your child? What are your goals, right? What are the short-term goals? What are the long-term goals? What do we need to prioritize right now? And what are we hopefully working towards in the long run? I think it's also really important that a provider asks you, what do you see as your child's strengths and weaknesses, right? We heard a lot of moving mountain stories from everybody here today. Those are all great strengths to know about. But it's also important to know, hey, where are those areas of deficits that maybe we want to be aware of as it relates to goal development as well. And then, of course, I think it's just always good to know, what are the kinds of things your child likes and what they like to do with you. That's really meaningful in terms of just a provider wanting to get to know your child and wanting to get to know the individual aspects of them. So next, when we're talking about staff training and supervision, here are some questions that I think you will want to ask. Who will be working directly with my child? If we're talking about a pretty traditional ABA agency, a lot of times you will have a BCBA or a BCBAD like myself who is supervising technicians or registered behavior technicians or RBTs who will be working directly with your child coming into your home. That's pretty common, but you should ask about that, right? What's the plan? Who's going to be coming into my home and working directly with my child? And then asking more specific questions, how are those people trained before coming in? How are they trained when they first get hired with your agency? And then how are they trained before you assign them to work with me and my family? Another important question, again, these are framed more as you're asking the Dr. Ilas of the situation, the BCBA who might be doing some of the supervision, how often will you be present to supervise or provide feedback to this technician working with my child? The technicians don't always have the largest scope of education and training, right? They've been trained to implement a procedure or a protocol that you've worked with your BCBA to develop and collect data to help measure that. So we want to know that that BCBA is going to be regularly observing that individual, making sure the procedures are being implemented the way they wanted, and that that data is being collected accurately and helping making those decisions. And then really, really importantly, again, hopefully that BCBA is going to be checking in regularly, but you should be asking, what is the procedure if I have questions or concerns that the RBT can't answer, right? You're going to have meetings hopefully with that supervisor, but if that's once a month, Well, what about in the interim, right? You don't want to hold on to questions or concerns for more than a day or two if possible. So what are the procedures for that agency for you to get in touch and voice those concerns as quickly as possible? And then again, questions that I think you should be asked by a provider are there any cultural or religious considerations that we should be aware of prior to working with your child or with your family? That is, again, just all goes back to the applied aspect of ABA. It's not up to me to determine what we're working on or how we're working on it. If there are things that would be helpful for me to know in terms of the materials that I introduce to work with your child, or when we schedule appointments, I want to know that, and I want to know that ahead of time. And you should be asked that by any provider that you're going to be working with. All right, data collection and measurement, right? Many of you may not be an expert in data collection and measurement, but I still think that you should be informed of the kinds of questions you might want to ask. So first being, what kind of data are you going to be collecting, or what kind of data will the RBT collecting, right? Is it based on the goals that we're targeting of adaptive behavior we're increasing? Is it looking at the challenging behavior we're trying to decrease? Get an understanding of that. Ask those questions and make sure it's clear to them and to you now that you know the behaviors need to be precise and measurable and observable, right? You can do some checks there. Are these behaviors that the BCBA are reporting to you that the data is going to be collected? Would you say those are observable, measurable, and precise? Then ask how often are they going to be reviewing that data? Again, what I love about ABA, and something I pointed out in the good, is that we're able to measure and look at progress pretty quickly, right? That's not to say that we have one bad day, we drop everything and we change things, but maybe if we have 3 bad days in a row, that's a sign we need to make a change. Conversely, if we have 3 great days in a row, good, that may be a sign we get to move on to that next skill. So if they say they review the data once a month, or depending on how often they have appointments, every 20 to 30 days, well, that you might miss a lot, right? You might spend time doing an intervention that actually isn't that effective, and you might have been aware of that if you reviewed the data every 5 or 6 appointments, let's say. And then I think it's great if you were to ask, what data should I, as a parent, be collecting outside of therapy sessions that might help measure progress, right? If they're working on behaviors in therapy sessions that you might start to see outside of there, especially when it talks about communication, right? If they're working on vocoverbal output and they're saying, here are the target words we're working on, you can collect data when you hear your child say those words outside of therapy sessions, which might help move towards that progress goal. And the questions that I think you should be asked are just that. Are you able to collect data across the day or between therapy sessions, right? You don't have to be on a keyboard or have some app on your phone where you're taking all kinds of data, but if you're willing and you're able to say, yeah, if you give me a data sheet and I just need to track a few things, I can do that. That just further adds to you being a part of your child's ABA team. And then another question I think you should be asked is, do you want to help review the data with us, right? Maybe you're not doing that every week or every 5 appointments, but maybe you review the data with them once a month. And you can see how they're making those decisions and asking questions about things that you're seeing or not seeing as it relates to the progress your child is making. All right, another important area, intervention approaches. So here are some examples of questions I think that you guys should be asking as you start this journey. What reinforcement-based intervention procedures are you going to be using? They might not know that right away, and that's okay too. If someone says, if you ask this question in the first appointment with a BCBA and they say, I have no idea yet, then that's an honest BCBA, right? Because they got to collect some assessment data, they have to get to know your child. They might not know, but maybe based on the goals that you've outlined, they're able to say, here are some ideas I have of how we're going to work on communication, work on compliance with hygiene tasks, or whatever specific information they might have at that time. Another question asks, what are the alternative or replacement behaviors being targeted, right? It's not just about improving compliance or reducing challenging behaviors, but what is your child learning, right? What is added to their repertoire of independent life skills? And then if, big if, a BCBA were to suggest a punishment procedure, hopefully that's something that's happening way later, but ask that. Have you exhausted all reinforcement-based procedures and said that they aren't working for my child if you're thinking that we need to go down the road of using a punishment procedure? And then ask to see the data. Even if you don't understand it, ask to see the data, because then they have to really show you how they made this decision, and that will give you a good insight as to, what are they working towards the goals that you've already identified as part of the team. And the questions I think you should be asked, very, very, very importantly, are, does this intervention seem feasible for you to implement in your home or in the community, right? ABA isn't just we do something and then a skill is mastered and you as a caregiver aren't involved, which I'll talk about in a second, but it may be things that you need to start changing your behavior in certain contexts. So again, I referenced the clinic that I currently work in where we're in a blue padded room. Anything can work there, but that's not meaningful at all if it can't be feasible for that parent to implement in their own kitchen, in a restaurant, at the grocery store. So getting that input from a caregiver early on, does it seem feasible for you to implement? Then we save time and we save our resources. If they say, nope, not at all, okay, well then we gotta try something else. Similarly, do you agree with the approach being taken? Is this meeting the goals that we outlined together at the start of services? That type of a question should be asked of you regularly by your BCBA or by your provider as you get working together. All right, I think this is the last section. And while I have this as the last section, this is something that you should be asking about from the get-go in terms of your own training and the generalization or that generality piece that I talked about. Right? Asking, how am I, as a caregiver, going to get involved in these therapy sessions? Unfortunately, I've worked with a lot of families who have said that when the technician comes to their house, they take their child, they go down to the basement, they close the door, and the parent has no idea what's being worked on, right? That may be okay every now and then. You don't have to be there for everything, especially if they're starting something out, but you need to be involved in that process as early as possible, even if it's just observing, so you have an answer to those questions about, does this seem feasible? Is this working towards the goal that you have? But eventually you're gonna need to be getting trained. And so if you've been watching, if you've been a part of those conversations and getting involved, then that just prepares you to be trained so much more quickly and more thoroughly. And then I think it's really important that from the beginning, you start asking about that generality piece. How do you, the provider, plan to generalize these intervention targets to the home and community settings that are meaningful for our family? You can ask that from the get-go. They might not know what the intervention's gonna be, but if they don't have an answer or they don't have an idea of how they're gonna help you make sure these things work outside of a therapy session, then you might wanna start asking some more detailed questions. And again, questions that you should be asked include, how do you learn best, right? I'm talking about you getting trained. You need to be able to express, how do you like to receive that feedback? How do you like to learn? This happens to me all the time. I'm very much a visual learner. So when I'm meeting with staff that I supervise and they're talking about an approach that they want to take, I stop them and I'm like, I need you to draw it for me, right? I need you to draw me some fake data so I understand how you want to measure and evaluate this, because just saying it to me, even though I've been doing this for 10 years, is not the way I learn best. I need to see it, and that helps me understand it. The other questions that you should be asked by a provider are, what contexts are relevant for you, right? It may be that you're like, oh, I don't ever plan to take my child to the grocery store. That's not relevant to me, but I want to be able to go to a restaurant. So that's where we need to practice these skills. Again, that's not up to me. That's up to you to tell me what's meaningful for you and your family. What are the contexts that we really need to target? This is the front 2 pages of a very detailed document on, again, I know it's from an autism website, but it's a really, really helpful tool breaking down in even more detail some of what I've talked about today about making informed decisions and understanding ABA. On their website, the autismsociety.org website, they actually have 3 different versions of this document, all with a varying level of detail. So if you're like, this was a lot, start with the one that has the least amount of detail, right? Start learning about it if you're just getting into this process. But if you're already working with an ABA agency and you're like, you know what, I want to know more, go to this more thorough one and take some time to look through some of the questions and some of how they've expanded even more on some of the things I brought up today. Also, if you are a learner who likes to read journal articles, this is a really, really great article written by a large group of authors. So this group of authors includes not just people working in academia, but practitioners who are BCBAs in the community. Some parents are a part of this author group, as well as 1 or 2 individuals with autism. And they go into a much more thorough discussion about some of those concerns that I touched on. Excuse me. If you are interested in reading an article like this and you can't access it, please feel free to email me and I'd be happy to send it to you. Lastly, I was at a conference earlier this year, the Association for Behavior Analysis International, and Eileen Lamb was there. She is a parent. She has autism herself and has 2 children with autism. And she gave a fabulous, fabulous talk on her experiences with ABA. She touched on some of the good, some of the frustrations she's had over the years. She also works for Autism Speaks. She's the director of their social media. She is a great reference that I wanted to give to you guys as a parent. Again, there's a lot of focuses on autism, but she talks a lot about her experience as a parent. One of her children engages in pretty severe, challenging behavior. And most recently, I was actually reading one of her blog posts where her son was actually kicked out of ABA. She is a big proponent of ABA, big advocate for good ABA, and her son was kicked out because he was not attending I think it was the 80% attendance expectations because he was going to school. And she, again, in a great example of how frustrated she was able to tie to the collaboration she'd established with this agency, talk to them about it, and per what I read in her blog post, they've come to an agreement and they've adjusted his schedule so that he can continue to go to school where he's doing great, but also continue to access these services that have been so helpful for him. So Eileen Lamb I think she's a great, great representative. I learned a lot from her, hearing her talk. She's on Instagram, lots of things there. If you ever see her name and have a chance to go see her speak, I would strongly, strongly encourage it. And that is all I have for you guys today. I have no idea what time it is, but I'm happy to take questions if you have any.
If anybody does have questions, I can bring around a mic so everybody can hear what the question might be.
Hi.
Hi.
My daughter actually has been attending ABA for a couple of years.
Yeah.
And she's been having tremendous progress with everything. Some of the technicians use like one approach. Well, one of them uses like a very, I'm gonna say like active approach that actually grabs her head sometimes to focus on some things, not very aggressively, because she tends to always go down and she tends to focus her sight to what she's doing.
Yeah.
And the other is more passive, but she seems to love both interactions. And what I've noticed is that when I go there to see what she's doing, she either uses me as an excuse to get out of an activity she doesn't want to do, or she's mad because she's enjoying it, and she's like, "Go, like I don't want you there."
Yeah.
So I guess just sharing that experience, like in order for us to get more involved with her ABA learning, like what would you think would be reasonably good for us to do?
Yeah, I think that's a great example, and is something that in my clinic we face a lot, where we have the luxury of being in a room with a one-way mirror, and so we will go in, and the Winnickeys may be able to comment on this too, where our staff will go in and work with a child, and the parent is standing behind this one-way mirror going, "That's not my kid." Like, no way. Like they're not doing that. That's insane. And so that sort of change in behavior is exactly why I want parents to get more involved. So it may be talking to your team and saying, "Hey, wherever in your home that they're doing that work, that you don't come right up to them, but you like sit back in the room, right? That you're just listening. Maybe she doesn't even know you're there necessarily right off the bat. And you just slowly incorporate yourself into these sessions. So she's not thinking of it as, this is where I do my work, and mom and dad aren't part of work, and sort of fade yourself into that, because what we want to see, again, I don't know what the goals are that she's working on, but that she can do that with you too, right? The more exposure that she might have to working on some of these skills, the more likely those skills are going to generalize to other situations, right? It's not just, I only do this when I'm seated at this table with one of these 2 people, but I can do this anywhere and everywhere with anyone. So I think that's a great question to bring to their supervisor or to the technicians themselves, to be like, "Hey, can I just sit kind of over here for 20 minutes and just watch? I'm not going to say anything. I just want to watch, and see, does that allow your child to kind of forget you're there and you get to be a part of it in that way. So that may be one kind of approach to take in a discussion with your BCBA. But I'm glad it's been a good experience for you guys. Yeah.
based on last year's conference,
Yeah.
you recommended that we have more autism, at check, and she was diagnosed with autism.
Okay.
In our area, the ABA centers are relatively limited.
Yeah.
There's maybe a half a dozen in the Quad Cities.
Yeah.
And we're currently, through the pre-approval process on a wait list, and they basically say, oh, we'll just let you know when you're up.
Yeah.
What does that mean? I know in my business, I couldn't just tell people, oh, I'll let you know someday when we're going to be there, when you're going to come to the top.
Yep.
Is that the way most centers are? Or will they give you a timeline or a number of people you're behind, something along those lines?
It's very, what you're saying is not uncommon, unfortunately. That is something we hear in Maryland. This is the case a lot as well, that there are a lot of agencies out there. They might not have technicians at that time, so there is this idea of a wait list until they hire someone who works in your area, or until they just hire more people in general to take on more cases. It's a catch-22, right? Because the other part that I didn't go into specifics about with ABA and some of the bad is that, and I don't have the full grasp on it because even though I'm a BCBA, I don't bill insurance codes for ABA, bear with me for a second, but the reimbursement for insurance for ABA codes is pretty garbage from what I hear. So agencies are sometimes forced to take on more cases, more clients like you guys, but then the BCBAs are stretched so thin that they're not providing that quality oversight. So in some ways, when I hear an agency saying, we're not just going to keep taking cases to fill slots, I think of that as a good sign because it means they're not trying to stretch themselves too thin and that they're focusing on the quality, hopefully the quality of care that's being provided. The downside being families are like, okay, we're approved, let's go, let's get working. We got goals we want to work on. And so it can be a challenge and what you're experiencing is not uncommon, but it's very frustrating. And I don't know if I really answered your question there, but.
Well, so do you recommend just going out and getting on every wait list and whoever can get us in first?
So yes and no. Go on every wait list, but don't just take what you get without asking some of these questions.
Go through the assessments, ask some of the questions, and then potentially look at it and go, well, I don't know if this is a good fit. We're going to wait. We're going to keep waiting elsewhere.
Yep. To share another example of a family I work with, they were on a wait list for many months at multiple agencies. Got sort of approved by 2 agencies. One agency sent a staff member over who the parent 20 minutes into the observation was like, what kind of training did you get? Unfortunately, this client engages in pretty significant aggressive behavior. And the technician said, I didn't get any training. So this agency sent a completely untrained individual into the home of a client that they'd approved for services, knowing they engage in highly aggressive behavior. And that parent said, you can go home now, I'm very sorry. Called the agency and said, take me off your list. I don't want to work with an agency who would do that.
How common is the in-home versus like going to an autism center for half day or full day?
50-50.
50-50?
Yeah, some
Okay.
agencies do both. Some will authorize both. Some may say, hey, we're going to focus on in-clinic for whatever your goals are, with the goal of working towards that in-home. So that's not necessarily like red flag either way, as long as it's a discussion with you guys about what your goals are and where it's going to be meaningful to make that progress.
Because from what I've seen, it's like they either want full day or half day, almost like full time is what it looks like. Is that pretty common as well?
It is, and unfortunately, I think that ties to a lot of outdated literature saying you need to do 40 hours or you need to do 20 hours. And there's really a lot more research that's come out lately saying the number of hours doesn't directly tie to progress the way we thought it did like 20 years ago. And so if an agency is really like stuck on the amount of hours piece of it, that may be a discussion where you really want to go to them and say, we don't care if it's 20, we will take 10. Like, let's just get started here on this process. And again, some of it's they don't want to stretch too thin or take on too many cases, but that bugs me only in that it's not tied to the individual need. That feels a little too rigid.
Well, and for Paisley, she kind of flourishes at school. She's part of that community.
Yeah.
And if she just goes full time, you yank her from that program and she may or may not be able to get back in in a year or 18 months when they say they're going to, scale it back.
Yeah. Yeah, it's a difficult decision-making tree, especially if an agency's saying, here's our very structured options and pick one, and there's less of that flexibility. Right. But that's where you have the conversation, and if it's not meeting your goals, then maybe it's not the right time or it's not the right agency, and it would be worth waiting a little bit longer for.
Okay.
The other thing you guys can do, again, I'm a psychologist and a BCBA. I don't practice in an ABA clinic. I practice in a mental health clinic, a psychology clinic, but I do ABA. So there is some areas where you might be able to seek out a clinic or a setting or a program that does ABA that's not an ABA clinic, if that makes sense. So if you can find a psychologist or a social worker, a speech language pathologist who practices ABA but might not bill ABA, that can open up doors for you to access these types of services without that autism diagnosis.
Okay, well, we can talk further about it when we all sit down this week.
No, but that I'm glad you brought that up, because that is a very common, get on a wait list, but I would say yes, get on every wait list you can, and be prepared with the questions that you want to ask before you determine which agency you're going to go with.
Okay, thank you.
Yeah.
Any other questions? Oh.
I'm sorry, this ain't necessarily a question. Just something popped in my head.
Yeah.
I worked at a detention for 14 years, and dealing with the legal system, your speech on punishment and everything, same thing applies for there. The legal system will eat you up.
Can you just get a little bit closer, sir?
If you even think about using the term punishment.
Yeah.
So for the legal system, for our term, and it sounds a lot better, we had to use the term corrective action, or we redirected them.
Yeah.
And it just sounded a lot better.
Yeah, well, and it's hard. I work with a lot of parents who come in and they say, well, we punish the child for this. And I have to say, well, has that changed the behavior? And they're like, no. And then I say, well, that's not punishment then. You know, you deciding, or a practitioner saying, we're going to, and this goes the same for reinforcement too, if we want to use that, right? If you say, I'm going to reinforce someone's behavior and we don't see the behavior increase that we're trying to increase, then that's not reinforcement, right? Because we need to see the change in behavior to sort of retroactively say, was that reinforcement or was this a punishment procedure? But yeah, I think unfortunately way back when behavior analysis determined that term punishment going to be used, you know, it's created a lot of misunderstanding about what that means. So thank you for sharing that.
Last call for questions for Dr. Ila. I put a link to the Sign Up Genius. Oh wait, we have Rebecca. I put a link to the Sign Up Genius for appointments with Dr. Ila on the team app. If anyone is interested, there are some appointments left.
Super fast, not really a question, just Dr. Ila saw us in 2019 at Utah and helped us told us and helped us identify so much of what was going on with Belle here. And Isabel, we were able to, state of Texas, if any Texans in the room, only does it for autism. And mind you, you also have to have autism diagnosis not through your school district, so don't waste your time there. Go get it through a medical practitioner. It has to be that, or insurance will not cover it. But we were able to negotiate all that. No, you may not have that. And she has made huge, huge milestones. She has been in full-time ABA for the last 2 years, and it has changed our world. She is so much safer, and thank you.
I'm so happy to hear that. Thank you for sharing that. Awesome. Good job also. Good work. All right, well, thank you all so much for your time today, and please stop me if you have questions, or hopefully I'll see many of you over the next couple days.